Hello, this is Ed Shahady, Dr. Ed Shahady. We're here at the Cardiometabolic Risk Conference in Las Vegas, and we're lucky to have with us today two of our speakers, Dr. Jim Matera, who's a nephrologist, Dr. Peter Jones, internist and lipidologist. Well, welcome to both of you. Thank you. Appreciate your speaking at the conference and also being here.
Thank you very much.
Well, I want to ask you guys some questions, and please feel free to interact with this. I'm starting out with chronic renal disease.
Yes.
Jim, that's something that, is primary care docs we get scared about. But, with our diabetics, what have you, we watch the GFR, we watch the creatinine. So if I have a patient to say the GFR is like 55, what type of things should I be doing different than when it was higher than that?
That's a great question. And as we move towards a different scale away from value-based medicine, or away from volume-based medicine to value-based medicine, there's a lot of that we'll be looking at. So many times we'll see that particular patient, but we really don't need to follow them long-term because the likelihood of them progressing to end-stage renal disease, which would be devastating, is very minimal.
Right.
So in that, what we would do is a good history and physical. We'd identify any of the causes that you would commonly see, hypertension, diabetes, cardiovascular disease, lipid management, and we can actually set some guidelines. So when I may see that patient in consultation, I would feel comfortable referring back to you with some ideas on when that patient would need to see us again. As the GFR declines, you start to see many more problems with that. In particular, once you start getting into phosphate-based management, those patients tend to get into very high calcium balance, contributing to cardiovascular disease.
Right.
So
when does that come? What GFR do we start worrying about?
Usually we'll start to see that in stage 3 chronic kidney disease.
Okay, so that's pretty high GFR.
That's still pretty high GFR. So our recommendation is we start monitoring at least annually a phosphorus and a PTH level in stage 3.
Okay.
Stage 3.
Stage 3 would be between
A or B?
Usually B.
Okay, stage 3B.
Stage 3B.
Okay, so that's 45 to 30.
That's 45 to 30.
Right.
That's
Okay,
when
good
you'll
point.
start to see those things. Your stage 3A patients, we generally don't have to be concerned about that.
Okay. So I can message there is maybe follow the GFR, and
Absolutely.
if it starts getting down close to 3B, that's going to be a good idea to talk to the nephrologist.
Absolutely.
Okay.
And you're going to do the same things that you would do normally for that patient management
Okay.
and try to prevent their progression through stage 3. The vast majority of the patients are in stage 3, and very, very few of them will actually progress further.
Okay. Well, let's look at cholesterol management in chronic renal disease.
Okay.
Dr. Jones, I think that before the SHARP trial, I guess we didn't have anything that said it would help but change outcomes. So how should we review that? And I think, if they get pretty bad, I guess the lipids-lowering drugs are of no value. So how would I deal with a patient, whether they're stage 1, 2, or 3? How should I approach treating their lipid abnormalities?
Well, I will start by saying that chronic kidney disease by itself is a predictor of risk. So you can use CKD as a decision maker in deciding when to start statins. So you can have that as an identifier to open up the discussion with a patient in primary prevention. You might benefit from a variety of preventative techniques, of which lipid treatment would be one.
Right.
I will say that most of the statin trials did not enroll patients specifically to have CKD, but some did. So in subgroup analysis, the patients with eGFRs less than 60 got just as much benefit as patients with eGFRs over 60.
Yeah.
Now the SHARP trial did. Everybody had to have CKD in order to enter. And most of them did not require dialysis, but about a quarter of them were on dialysis. The entire group of patients did benefit. There was placebo versus the statin treatment to lower lipids in primary prevention, and the statin treatment did reduce cardiovascular events.
Right.
It was driven mostly by the non-dialysis patients. Those on dialysis didn't seem to get much benefit, but fortunately the majority of the patients weren't on dialysis and they did get benefit. So the recent ACC/AHA guidelines about statin treatment in patients with CKD suggest if you're already on dialysis and you're not on a statin, starting one probably isn't useful, and I think you would agree with that.
I agree.
But would you say that if a person has not been on dialysis, has been on a statin, but progresses to dialysis, you would probably say continue taking the statin?
The statin in those cases, yes. almost all of our dialysis patients, except perhaps some of our younger glomerular disease patients, are in a positive calcium balance. They do have cardiovascular disease.
Right.
So I agree, the SHARP trial did show us that there was maybe not the benefit in dialysis patients, but on a patient who was on a statin, I would certainly continue.
Right.
One thing I'd like to ask is, we have trouble, of course, our patients are taking a slew of medications
Correct.
to begin with, and if we try to add a statin, they're often resistant.
Right.
So I try to go over why we want to have them on the statin, but it's a difficult task.
Well, it is. I mean, it is a shared decision-making approach. I mean, you have to present the data. You as a physician may feel it's in their best interest, but they have to agree to take it. They have to be not only aware of the benefits, but the potential risks. And of course, statins have a little bit of baggage with them and drug-drug interactions, but you can choose very appropriate drugs, which have been looked at in patients with EGFRs down to 15, like pravastatin and fluvastatin, which are excellent medications, and simvastatin was in the SHARP trial. So, I think you can make good drug choices with few drug-drug interactions and good tolerability.
Yes.
Do we need to change doses? I think when you read them, atorvastatin gets the best, marks for chronic renal disease. So if I'm using one of these others, do I need to be, knock the dose down something? What would it be?
Well, that's a good point. I mean, there's high-intensity statin, which is usually rosuvastatin and atorvastatin at higher doses. And then all the other statins are usually considered moderate intensity. I would say minimum and probably safest are to consider the moderate intensity statins. All of those are generic. The doses are reasonable. And so, but the high-intensity statins, if you had established heart disease, even with CKD, I would do probably rosuvastatin is probably the easiest one to use in patients with low EGFR. But if you're primary prevention, moderate intensity, other generic statins are wonderful.
Okay, because I guess if you want to look at what causes people with chronic renal disease to die, it's cardiovascular disease.
Correct.
So that's what we want to work on in chronic renal disease.
And the problem with the dialysis patients, why there probably wasn't a benefit on statin treatment, is the outcomes there are probably not lipid-based. They're complex cardiovascular outcomes in dialysis patients.
Very, very complex, and I alluded to the whole calcium balance issue. There are studies that have been shown with phosphate binders, getting away from the calcium-containing phosphate binders is a good idea. So we have a couple that are on the market, a new one just came out, so we are trying to do that, because all of our patients, by the time they either get to dialysis or stage 4, are in positive calcium balance, another independent risk factor that we try to modify.
Right.
Let me ask you a different topic. It's about, the new, ACC, AHA guidelines. A lot of controversy, disagreement. You and I are lipidologists, the National Lipid Association, doesn't like it. Like, I'll take one particular thing. You don't no longer need a goal to shoot towards, which ATP3 says you've got to have a goal. So how do we look at that now? What do we advise our primary care docs?
Well, that is a great question. I will tell you that the guidelines from the ACC-AHA are randomized clinical trial evidence-based medicine. You cannot argue with that, okay? And evidence-based medicine tells us that statins are far beneficial than they have risk under certain patient situations. Agree. The part that was controversial was the guidelines did not recommend LDL goals. That's because the randomized clinical trials didn't use goals.
Yeah.
All right, well, I understand that. So what the ACC-AHA say is at least a minimum that every physician should take. Identify risk. If you're high enough risk, offer them a statin, get them on a statin. That will benefit them. From a patient-physician interaction standpoint, you do need to talk about why I'm giving you the statin, what are we treating with that statin, and what are we following as a result of taking that statin. And it's the same with blood pressure, A1C, anything. The patient understands what you're doing and why they're taking a drug. If you're treating this, and it starts here, and it goes to here, and that means I'm taking the medicine, and I'm happy, the doctor's happy. So follow biomarkers. They're still beneficial and useful, and I will tell you that there's plenty of evidence to suggest the lower your LDL, the better are your outcomes.
So what goals should we go for? What do you shoot for now?
I think optimal for everybody is minimally under 100 milligrams per deciliter. If you have established heart disease, then there's no reason why you should be under 70 milligrams per deciliter. That's very reasonable.
How about diabetics? Should we push them to 70?
I think there's no reason. If you can get if you can get them under 100, most of the time you can get them under 70.
Right.
But the higher your risk, the lower the LDL. So if you have a diabetic, age, chronic kidney disease, yeah, they're piling on the risk. I would get their LDL as low as possible. If they have established heart disease, absolutely less than
Okay, well,
70.
what about chronic renal disease? You alluded to it. Do you push for a goal in chronic renal disease?
I do. I agree that 100 is kind of our marker. We're using that in a lot of our performance-based
Right,
metrics
right.
now. But certainly my patients are going to have established heart disease, by and
Right.
large, a vast majority of them. So I target a goal of an LDL below 70 in those patients as well.
Okay,
Yes.
good. Let's switch to blood pressure, because of recent controversy too there, JNC late, I mean
Yes.
8, came out and, they changed it, for chronic renal disease, I thought at least a 130 systolic is where I wanted to go, sometimes 120. And now they're saying if you're over 60, let you go to 150. Well,
Yes.
docs are having all kinds of trouble. So from a chronic renal disease perspective, what are our goals for blood pressure?
Well, you stole my joke. I was going to use JNC late at my lecture.
JNC
today.
late.
And then everybody became JNC irate.
Irate. Very good.
So it took a lot of understanding, because when I first started practice, I used to tell patients, especially with diabetes, that we had 3 goals in managing their kidney disease: control their blood pressure, control their blood pressure, and control their blood pressure.
Yeah.
We didn't really even talk about sugars back then.
Right.
Now we've added that on. So JNC8 kind of took us a little bit, not by surprise, but I think what we found in JNC8, and I'm sure Dr. Block and Dr. Taylor will allude to this tomorrow as they do a deeper dive on this, is that the evidence to go much lower than these levels didn't seem to confer any added benefit. So that being said, what I'm telling my patients now is I'm going to target you at 140 over 90. I'll be okay with that. You'll be okay with that. What they're taking home from this, though, some of my patients, I don't know if you've seen the same, is they're telling me now that they're being over-medicated if they're better than that. So I'm not backing off on their therapy if they come in better than, 120 over 70. There are some studies out now that just have come that actually going too low in chronic kidney disease may impart a negative risk as well. So we balance this. I always tell patients that we want to get their best possible blood pressure goal to help slow the progression. We know that that does happen.
So you're telling me chronic renal disease 140 over 90 is my goal?
I'm 140 over 90. I tell my patients I lower the bar, raise the bar a little bit. 135 over 85 is what I would like to see.
Because the ADA is still 140 over 80.
It is.
Yeah,
It
okay.
is. And
What do you say, Peter? Because you deal with hypertension, if
Yeah.
you deal with lipid problems, yeah.
Well, I mean, there's similarities here. Again, it's primary prevention, secondary prevention, and the intensity of treatment. And I do think in diabetes and some evidence of chronic kidney disease, that you should get systolic, diastolic blood pressure down. It should be under 140 over 90. I do agree and concur to some point with the new guidelines that the older a person gets, over-medication and too low a blood pressure contributes to falls and other issues that are a problem. So I will talk with an older patient about maybe over-medication. But certainly younger patients, I don't really ever discuss getting too low. I mean, I
What's
think,
older and younger?
well, that is a personal decision between you and the patient. I think, yes. I mean, I think when you get to be 75, 80 years old, yeah, I mean, age is what it is, and that's going to trump. Underneath that, there are a lot of young people at 70 years old, a lot of old people at 70 years old. That's an individual patient decision with you and the provider.
Frail.
Yeah, that's a good point.
There's a certain way you can try. Yeah, that's
Correct.
I cut my teeth when the SHEP study came out, systolic hypertension in the elderly, which is now politically incorrect.
Yeah.
So
Right.
we don't use those anymore.
Right, interesting. Well, gentlemen, this has been wonderful. Thank you very much. Appreciate you being here.
Thank you very much for asking me.
Very good.